Welcome to In the Interim. This is a program that we've put together to help bring some of our faculty and some of our alumni in front of our student body, where our students can come and network with these VIPs that we've brought in. And today we've really brought in a VIP. We brought in Jason Pogue. And Jason is a clinical professor in the Department of Clinical Pharmacy here at the University of Michigan. He did most of his training in Pittsburgh, but he did his PGY2 residency in infectious disease at the University of Michigan. And his research here focuses on epidemiology, management of multi-drug resistant gram-negative organisms, and antimicrobial stewardship. But he's more than that. He is president of the Society of Infectious Disease Pharmacists, and he does a whole bunch of things that I want to talk about today. I want to also say, Jason, that you win the award for the guy who looks the least like his picture on the faculty website today, because you seem to be sporting a COVID beard. So welcome, and thanks for being on the program.
Hey, thanks for having me. And yeah, 6 months, you not letting me come into the building. This is what you get, Dean Mueller.
Apparently you only shave in the building, we're finding out. Is there a shaving plan in the future at all?
Yeah, I think the goal at this point, I'm kind of just riding it out. I think that my current plan is that this is going to be a period piece for me. And so when I get my vaccine, that is when it will go.
The COVID vaccine is also comes with a razor.
It comes with a razor, that's right.
That's good to know. All right. Well, I'll tell you what, we're going to talk about a bunch of things today. And what I want to do is make sure that we invite the audience to participate as well. So there is a sort of a raise your hand function if you'd like to ask a question. And I definitely at the end of this program, we'll invite everybody to be part of it. But if that's not what you want to do, if you're shy, you want to just type in your answer in some way, well, we can do that too. There's a Q&A form that you can certainly type in a question, and I'll work it into the program today. So please don't be shy. This program is actually for you. Otherwise, it's Jason and I shooting the breeze like we like to do anyway. So let's get started as they think about what questions they want to ask. And I've got to ask you about the background. Either your dog sits very still and is well behaved, or you've got a new background.
It's a new background, but it highlights our new beagle. That is Pliny behind us. We got her, Dean Mueller, the week before the world shut down. So she is under the impression that daddy is home all the time. She's a big fan of pandemics, and she's in for a rude awakening sometime.
That's what everybody's saying. Their pets are being so horribly spoiled, except for the pets that were older who were saying, when are you going to get out of my house? Particularly cats are saying this, is what I'm understanding.
Yep.
All right. Well, so you do so many different things, and I kind of want to hit a bunch of them, and maybe describe a little bit what your role is currently within the College of Pharmacy and Michigan Medicine. What are you working on?
Yeah, so good question. So I came back to, so for those of you that don't know me here, after I finished my residency here, and Dean Mueller was actually my faculty mentor while I was here once upon a time. And I went to the Detroit Medical Center, where I was there for about a decade, where I practiced as a day-to-day infectious diseases pharmacist. So again, interviewing on patients predominantly, developing guidelines, pathways, algorithms, really looking to optimize antimicrobial therapy. What brought me back to the University of Michigan was the desire to, in addition to continue to take care of patients, I wanted to focus more on clinical research. And that's what brought me back to the school. And as Dr. Mueller described, my focus is largely on multi-drug resistant gram-negative organisms, as well as antimicrobial stewardship. But I will tell you that much like everything else, there's a COVID side story to that, where whenever, again, a lot of the grant processes that we were waiting on are on hold. Whenever, COVID happened, we were using a lot of therapies that we didn't know. We really didn't know what we were doing. So really, I kind of shifted gears a little bit to focus on investigating the outcomes that we were seeing in the patients with the therapies that we were given. But on a broader scale, one of my big interest areas, and one of the things that a focus area for me at Michigan that we're starting to look at, is management of drug-resistant Pseudomonas infections.
All right. So you mentioned COVID, but I can't talk about COVID until I learn the name of your dog pre-COVID. It's not named COVID, is it?
No, dog's name is Pliny. She is not named COVID. So
okay, that's good to know. All right.
Yeah.
Okay, so what is it like being an infectious disease pharmacist? I know you have interest in gram negatives, but all of a sudden a pandemic hits. Your job description just changed overnight. I know that yours really did.
Yeah, and I would say that, so yes, it did, but I would say that everybody's did, and again, while mine, it's very interesting to be in the specialty where this is happening, but I'd be remiss if I didn't call out our colleagues who work in the ED and the ICU, whose world even more got turned upside down in a patient care way, where they were dealing with a ton of patients. They were, on third, fourth line things for sedatives, all of this type of stuff. And they were putting themselves in harm's way. So I do give mad props to, particularly at the early pandemic, because we didn't have therapies, we didn't know what worked, and really supportive care was the mainstay and still is an important piece. But to your point, yeah, it's been quite the experience where, the world outside of COVID stopped. All of a sudden, my parents cared what I did, and they were interested in what I did, and they're like, "Oh, that's what you do." But what was really nice, Dr. Mueller, was that we were able to really, again, as ID pharmacists, our job is always, analyzing data, investigating optimal therapies, developing treatment pathways and algorithms. And what was nice is that we were able to apply those skills to developing pathways for COVID. The difference was, of course, that this is a novel virus that we had very little data to go off of. But I will tell you that in the early going, those same types of skills, though, literature evaluation, looking at in vitro activity, dosing, those types of things. I'd say that since the beginning, though, one of the biggest things has been literature evaluation. That is a fire hose of information that is being put out there. The majority of the data is garbage. There is a media interest for both positive and negative reasons. There is a governmental interest for those things as well. And so again, having what we do, which is ID, just be thrust in the national conversation has been a really interesting, exciting, overwhelming. You pick your favorite adjective. It's been all of those things.
Well, it reminded me a lot. My career started when HIV was starting, before we knew we didn't call it HIV. And it was a similar thing where people were getting sick. We didn't know what it was. And we threw every drug we had. And some worked and some didn't. And there were all kinds of myths about what really happened. And this same thing happened with COVID. And, here we are using malaria drugs. We were just pretty much opening up the formulary and putting it into patients and then trying to count if it worked or it didn't work.
Yeah.
And that's where and then you had people from governmental agents saying this works, that doesn't work. Facebook had opinions on what the drugs of choice were for different things. The other thing that I thought was weird, maybe you could weigh in on, is you talked about literature evaluation, and it is still really, really important now, and I'm glad we teach that our students that, but the literature didn't even get to be literature. We were getting pre-printed stuff that somebody wrote and submitted to a journal, and all of a sudden it was gospel. It hadn't gone through peer review. Some of the early stuff was coming out of China because they had a little bit of a head start on us on what they were seeing. But talk about how do you evaluate literature that you're not even sure is literature?
Yeah, and this was a huge challenge. And I would say that even in addition to that, there was evidence by press release that still occurs, is that you get like, hey, this saved lives, and then the data don't follow for months, and you're in this forever limbo. But what I would say, Bruce, to that is that, again, it is our job, it is our role to be the peer reviewers. And that's something that we kind of took pride in. I know personally it's something that I took pride in, that again, the frontline clinicians were getting hundreds of patients at a time, right? The ones who were at the bedside trying to manage these patients just did not have the time to get into the intricacies of these data. And to the point that we brought up, there are sound bites and news clips if you say things that are, I found a cure, there's a benefit, there's this type of thing. And so really for us, and for me personally, it was reading those studies. This became a full-time thing that we would look at these data. And what was really interesting, Bruce, is that, as you know, and for the audience, I do observational research. That's what I do. That's my primary thing. And I do believe in well-performed observational research, but a pandemic totally changes the game, because for observational research, you have to have comparable groups. And what you find is that in the real world, for a number of reasons, treated patients and untreated patients, it's hard to get like patients, right? There's a reason that they're getting treated. There's a reason that they're not getting treated. This isn't comparing a new drug versus an old drug. It's legitimately giving therapy versus not giving therapy. And there's a lot that goes into that. And so as that evidence started to come up, it was really important that we gave it that thorough evaluation.
Well, when there was this other pressure, and it was this time pressure that we have. Like if I've got a study and I work on it today and submit it tomorrow, or I submit it next week, I know it's publish or perish, but there's not the pressure that people's lives might be changing every day if I don't get this out. And so that pressure was felt by authors trying to do stuff as fast as they could, but also clinicians trying to learn whatever they could. And often papers, neither of which went through much peer review, had opposite effects. Hydroxychloroquine being, a really good example of that. It's still being argued about on the Facebook and Twitters of the world. And it was really hard to know what was truth. And you were a guy who was out there sort of, for a gram-negative guy, you sure became an antiviral person real fast. I was very impressed on your pivot.
Yeah, and one thing that I would add to that is that in addition to feeling for, because I've peer-reviewed articles, I continue to peer-review articles on COVID, and there's a pressure on that process too. There's a pressure on the journal editor, on the journals. The turnaround times for peer reviews are truncated. There's a little bit more leeway and gets accepted. So yeah, it's intense. But yeah, Bruce, to your point, boy, virology is not my thing, and I can't wait for it to not be my thing again. Again, remembering all the intricacies of helper T cells and responses, and again, that was another big pivot, is that the response to a functional antibiotic and a functional antiviral are very different. Again, you're just trying to kind of stop progression, whereas the other one you're actually treating, right? And so again, our mindsets going in with antiviral therapies probably weren't even appropriate, because again, things were just flying around left and right. And so to kind of back up, again, think of the flu as an example, right? Our mainstays of therapy have a relatively modest effect, right? It's not like the pre-antibiotic era versus today. It's a very different thing. And so, yeah, like I said, luckily my employer was nice enough to allow me the leeway to really, take on that role, which I just think that it's the responsibility of all of us to do so. It's just a really...
I want to follow up on what you're saying, because the evidence-based medicine, I mean, it's one of the threads in our curriculum. We stress it a lot. It's possible, and I'd say to any of the students, when you're P4s, if your preceptor is reviewing an article, ask to review it with them, because it's really cool to do, to serve as a reviewer for a journal. But all right, I'm going to give you the magic wand.
Yep.
You're in charge of the Jason journal of whatever it's going to be, and another pandemic comes. What would you do different if you run the journal? I mean, what like everybody was in a corner on this one, sort of doing the best they could. But now that you've lived through the wars here, what would you do different?
There's not an easy answer to this question, because the flip of that, Bruce, is that not all peer-reviewed stuff is good either. In fact,
that's right.
There's been retracted articles out the wazoo, and so again, we need to balance, and I think we're better at it now because we're a little bit further along, but to your point, it's going to be the same the next time this occurs, is I think we need to balance the speed with just even asking, is this even a reasonable thing? Again, we use hydroxychloroquine as the example, and it's not to get political, it's because it's where all the observational data came from, right? It's because it was the only thing that we had that we could easily give that maybe worked, but we felt it probably wasn't going to hurt people, and so it's where that all came in. But some of these publications, and again, peer review versus non-peer review, and a lot of times it wasn't much different, is that it didn't pass the sniff test. Like, again, if it works, there's a certain effect that you would expect to see. If it doesn't work, there's a certain way that would look. But you saw just bad science on both sides of that story. And again, I think that for me, it started early in the pandemic whenever the first hydroxychloroquine and azithromycin paper came up, is that like, hold on, does this make sense? And can we slow down and think about it? Because again, we're taking care of all these patients. It says, look at this magic finding in like 6 patients. And then you kind of, again, I had to learn what a cycle threshold was. I had to learn what I would expect to see with an antiviral, right? And so I think that it's our responsibility. So Jason's journal, that's the responsibility, is that thorough read has to get down. And not unfortunately, but at the end of the day, there's a huge responsibility on the editor, because that's the editor, the associate editors are who make those calls of whether or not things go through or not. And in their defense, they are getting many submissions. Everyone has an opinion. Again, if you looked in March, April, I thought the New England Journal became a blog, because that's what you were seeing, right? It's like, I think this, and then the news media would pick it up. And I mean, it's just
yeah, it was a zoo. It still is a little bit of a zoo. I again want to remind the audience, if you want to jump in with a question, you can chat it. You can do a question and answer thing. We can do live ones as well. And I want to really invite you. I want to change gears a little bit, because I was really proud of you when early in the COVID stuff, you became a missionary on social media, really stomping down bad science and political stuff that wasn't based on anything scientific. And we kind of live in an anti-scientific age. But if for those of you who don't do Twitter much, Jason's a really good Twitter follow. I want to talk to you about, this is sort of a new responsibility that we feel, because when COVID came out, I did what I can do. What can I do? I'm a nephrology person. I'm a dialysis person. I tweeted out, what are the doses or the likely drugs, whether it's azithromycin or anything else, and I put out everything that I think you should do. I couldn't publish a paper about it, but here's my expert opinion. This is what you do for dialysis. This is what you do for CRT. This is what you do for this, for every drug that we were talking about. You did a lot as well. You want to talk about sort of your missionary work? I'll call it that.
Yeah, I mean, like I said, to your point, Bruce, to a degree you feel helpless, right? Because like, I thought we did a really good job locally, but we didn't have a huge issue at Michigan with COVID. You know, Detroit was, again, a lot of our COVID patients here were Detroit overflow because of how hard Detroit got hit. And you see that, again, the loudest person was winning, right? And that's what was really concerning to me, is that you would get people, again, they were physicians, they were whoever, who would go on and they would make these egregious claims about data that were out there. And, you know, like again, we care about our patients, right? And I was concerned that, you know, they're not getting managed appropriately. People's loud mouths are exacerbating that situation. And one of the problems is we've talked about already, is that, you know, a lot of frontline clinicians do not have the time to read all of the papers because they're taking care of patients all day. And so for me, the natural fit with what we do, and again, I think this is what pharmacists do all the time, is just to do that literature evaluation. And so, again, there's a reason that I felt that hydroxychloroquine was not a good therapeutic option once I started to see data. And so just to kind of walk through that on social media, knowing that I won't drown out the loudmouths, but people will see a logical story. And in addition to that, my hope is that it lays out the evidence that they can then use to pass it on at their institutions or other things from that standpoint.
Well, there's a lot of responsibilities. I mean, when you put yourself out there like that, because that's not peer reviewed either, right? That's the opposite peer reviewed. But you put yourself out there, you're representing the university as well as yourself. But then I guess I'd be remiss if I didn't talk about what's on your shirt. You also are representing the Society of Infectious Disease Pharmacists, because you're the president. And did that change how you would respond to people or comport yourself on social media?
Always in the back of my mind. Again, representing Michigan is in the back of my mind, and being the leader of a professional organization that is the advocacy group for ID pharmacists is on my mind. And what I would say to that is, to be honest with you, both personally and professionally, that helps ground me. Again, SIDP, for example, has a mission, right? And is what I'm doing in line with that? I have a personal mission, and that is to improve the care of patients. Is what I'm doing in line with that? And that would be really what would drive. I feel that I have something to give in that area, but at the same time, you're right. And that is always a consideration that I have to take into mind. It's actually why I don't say a lot of things that jump up and bubble up a lot of time when others say things. It is absolutely a responsibility, but again, it's something that I feel is worthwhile.
I need a burner. Burner account. If I had a burner account, I could say a lot of things I really want to say, but I can't because of my role. So I agree with you on that. So you're the president. You're the first president we've ever had on the program. So congratulations. I wish you would, if you would be on the ballot, I might vote for you on the big ballot, not the SIDP ballot. But so talk about why would you're a busy guy already. Why would you put yourself out to do what probably is a lot of work, and you can tell us what some of that work is, but why do that?
Because I believe in it. And again, when I think about our profession, when I think about, again, SIDP, being the president of SIDP is just an honor and a privilege. And the reason I say that is because, again, the purpose, if you read, again, I'll say it again, our mission statement is to advance ID pharmacy, to lead antimicrobial stewardship, and ultimately to optimize the outcomes of patients. And there's nothing I want to do more than all of those things, right? And so when the opportunity is there to help push the direction of that, to serve our members, to help advocate, to, again, it's one thing if I say something on Twitter, but I want, again, there's so many people who are doing better things than I am, and to be able to help elevate them is just an amazing opportunity. And again, it's an opportunity to advance our profession. I think ID pharmacy, obviously I'm biased because it's what I do, but I think that it's just such a natural and important part of managing infections, right? I mean, the dose optimization is everything. The way you give the drug is everything. And I think it's important that that's known, and that we advocate for that. And if I'm able to help do that, like I said, it's a privilege.
How big is SIDP?
1,500.
That's a really big organization, actually.
Yeah,
I didn't realize it was that big.
It's grown. ID pharmacy has grown substantially with stewardship mandates and all of that type of stuff that has come. But yeah, it's a big organization that is increasing its footprint. And to be honest, it's cool to be a part of. It's been interesting to do it during a pandemic because you got to put out statements. You have to, okay, how are we as an organization going to help in this situation? Again, it's one thing when Jason rambles on Twitter. It's another one, a 1,500 person organization puts out educational materials, right? So working with our board to kind of develop that's been a really rewarding experience.
So what kind of important things can you accomplish? And I don't mean, for example, are you putting together guidelines for usage? Or do you have position statements? Is it whether it's about COVID? I know vancomycin recently came out. Can you talk about some of that kind of work?
Yeah, I'd love to. So first off, I will tell you, Bruce, that I had an agenda for my year, and it's completely scrapped because my year got hijacked.
It was gram-negative, and now it's viral.
We were going to do a bunch of things that came out, but no. So what I would say is we ensured pharmacist representation on all the treatment guidelines. So we have Susan Davis, Michigan alum, who's in Detroit. She represents SIDP on the NIH treatment guidelines, which is cool for COVID.
Wow, that's
Jason
cool.
Gallagher, we got him to represent SIDP on the IDSA treatment guidelines. So again, advocating, making sure that drug expertise was there. We developed and I encourage you to check this out, on our website. We have a COVID-19 resources page. So what we did, again, it kind of goes back to what we were talking about, Bruce, that we just want to help in this situation. And so what we did is we had all our members who are around the country who are, developing these pathways, doing the things that we talked about. We had them put together 15, 20-minute educational videos on the different drugs, remdesivir. And again, as new data became available, we would update those from that standpoint. We have a podcast called Breakpoints, again, shameless plug, that we would insert COVID material into as well. again, we would do those journal clubs. There's actually a section on our website where, because we know that not everybody can do that deep dive, and if for those of you who've done student journal clubs or resident, it's the same format because we're pharmacists, right? And so it literally just walks through a journal article like that to just provide that perspective. And then I'll say some of the more interesting stuff, Bruce, has been this year we partnered with, this is our first year as a partner organization for ID Week, which is virtual like everything, but that has enhanced our partnership with organizations like the Infectious Diseases Society of America, the Society of Healthcare Epidemiology of America, and so on. And so every time something would happen, there'd be statements that would be put out. Like,
well, tell people what ID Week is, because I don't think they know what ID Week is.
They don't.
I know it's a holiday at your house, but maybe not everybody in the audience is giving hand sanitizer to each other in their stocking.
Well, you should be. No, so ID Week is basically the big international, at least the one that's held in the United States, infectious diseases meeting that occurs annually. And so one of the big things that we accomplished last year was we got SIDP to be a co-partner of that meeting. And so this was supposed to be our, again, Bruce, when you talk about the things we were going to do, this was supposed to be like a huge thing for us. So this was going to be our first one. But it kind of didn't happen that way.
I know. I went to ID Week a couple times. It's awesome. If you have an ID interest, students, or you get a chance to go to a meet, ID Week is a pretty cool. There's so many things going on. There really are. Hey, there's some questions rolling in here I want to ask you. You mentioned remdesivir, and just using that as a jumping off point. We started, I mean, in February, nobody even knew what the heck a coronavirus was. And then next thing you know, in March, we're treating people. So how do you come up with usage guidelines when the data are practically zero? And you have to, because you can't just, because everybody who reads something in National Enquirer can't start writing for some new regimen or some new drug. Or, I mean, there was, don't use ACE inhibitors. Yeah, I know they're okay. Today I just read HMG-CoA reductase inhibitors. That's good if you're on those, but it's even better if you wear eyeglasses because you won't get it in the first case. Like, how do you come up with guidelines in a vacuum?
It's always about the zinc, right? So anyway, I will tell you that, again, acknowledge the situation that you're in. We do not know the answers to any of these questions, right? And so I will tell you, we have a great ID group at the University of Michigan. I'm very lucky to work with them. And, we developed our first treatment pathway based off of what we thought at the time. And I will tell you that we met daily for probably a solid 4-week period as something new was happening, and we tweaked it. We had hydroxychloroquine in our guideline. Within 3 to 7 days, we had taken it out based off of our experience and emerging evidence. Again, as clinical trials got up, we started shifting people to those, because that's really the key, is to get that good evidence to drive what we're doing. And so I would just say, but again, that hydroxychloroquine, and I hate to keep harping back to that, but the thing about that is that is one drug that was freely available to everyone. Remdesivir is IV. It was investigational. You can't just get that, right? Anyone can write a prescription for hydroxychloroquine. So outpatient concerns became an issue, right? And then they were combining it with azithromycin. And so pharmacy hats like, those both could cause the same adverse event with prolonging the QT. So I'm worried about that. So those types of things we were just constantly kind of evolving with. We'd reach out to the state if we had to make sure that we were in line with what they were doing, or if they were going to be doing something, we would voice our concerns. And so honestly, you do the best you can. You acknowledge what you know and you don't. And again, don't hesitate to turn when new evidence comes. I will tell you that hydroxychloroquine, again, I was a promoter of it at the beginning. I was like, why not do this? It looks good in vitro. There's minimal risk. Why not? And then as the evidence came out, don't hesitate to backtrack and say, yeah, I thought that now, but now we know this.
All right, we're coming to the end. If there's more questions, students should throw them in. I'll allow you to do a shameless plug of, there's probably some folks in the audience here thinking that maybe ID would be a cool career. Talk us through maybe how you decided to do that, and then is this a good career path? Because I don't know that our students know. They probably don't know, because they don't know any else better maybe, but we have the best infectious disease group in any college of pharmacy, bar none, and it's not even close. So talk about the ID as a career path, because not everyone's going to be a professor like you doing research, but you might be doing other things.
And one thing I will say, that because I know we're time limited here, anyone who is interested or even wants to talk about this, I'm available. Shoot me an email. We can set something up. I'm happy to chat about this in great detail.
I'll put your email up at the end when we're done here so everybody can get your email address.
Very good. But again, for me, it was, when I was a student, I was fortunate enough as a P2 that I had a summer internship in Danville, Pennsylvania, and that is middle of nowhere, Pennsylvania, at Geisinger Health Center. But they're actually very advanced in their pharmacy practice. Living in Danville was a different experience. But anyway, I digress. But anyway, as part of that experience, I got a week with all of the different specialists. And for me, so again, I learned what a nephrology pharmacist did. I learned what an AM care pharmacist, and so on and so forth. And for me, ID was just, it jumped off the page. And the reason for that is that, again, I say this because I mean it. It just seems like the profession, or the specialty, that is so tailor-made for pharmacy, because this isn't lifestyle changes, right? My wife's upstairs. We're not talking about limiting salt. We're not talking about, increasing exercise.
They don't know who your wife is. You got to tell them who your wife is.
My wife is Dr. Kristen Pogue, who's a cardiology pharmacist. And she was once my co-resident at the UVM. So she, but again, there are a lot of things that can be done there. But when you talk about treating an infection, optimizing that antimicrobial is really your intervention that you can make. And so picking the right drug, dose optimizing, where pharmacokinetics and pharmacodynamics have really revolutionized how we treat these patients, picking the right duration of therapy. So it was always a natural for me. And I went into practice as I wanted to do this. I wanted to help make antibiotic decisions. And so what I did for the first decade of my career is that basically if anybody came to my hospital, it was my job to make sure that they were on the optimal antibiotic, the right drug, the right dose, the right route, and the right duration. And I did that for everyone. Now that would mean stopping antibiotics in patients who didn't need it, but it was also, giving the, as they call them, big gun antibiotics when appropriate. It was increasing doses. It was.
But you had to think about economics too, because that also jumped in.
Economics absolutely comes into it, and again, it's all part of this dance that we do. And so what I would say is that for me, it was really rewarding to do that. But for me, my passion and the chemistry background was always as a clinical researcher. And so even when I was taking care of patients, what would happen would be like, what you'll find out if you ever look into ID is that, there aren't a lot of answers to most questions in ID. It's a very gray, you don't get big patient populations to answer it. And so we'd have these clinical questions that would come in our patients that we didn't know the answers to. And that would naturally lead me to translational clinical research. And so as I progressed in my career, I wanted to focus more on that because I thought I'd have a bigger impact. And so while I still take care of patients, I still work in developing pathways for antibiotic management at the hospital. My primary focus now is actually trying to answer those questions to drive those pathways.
And what's the job market looking like in ID?
I think ID is probably one of the better ones. And the reason that I say that is that, so something that's kind of taken off in the last decade has been this concept of antimicrobial stewardship. And basically all that means is optimal use of antibiotics. We're concerned that underuse or inappropriate use leads to bad outcomes in patients. And perhaps for some of the reasons that they've gotten more press, if you will, is that overuse will drive resistance. And we deal with a situation where we have bacteria that basically none of our antibiotics work. And so because of that, and the reason I bring that up is that there have been Joint Commission, there have been governmental mandates to implement antimicrobial stewardship programs to optimize antibiotics. And pharmacists are, again, in every one of those documents, pharmacist is a co-lead of that with an infectious diseases physician. And so outside of the entire pharmacy market, I think there will continue to be a need for ID pharmacists because someone needs to do this at institutions.
All right. Well, one last question just rolled in.
Sure thing.
Did you take, you did the PGY1, PGY2 sort of standard way. I remember Daryl DePestel, who was a previous one of our faculty. Remember, he was actually a medical technologist person, was a lab person first before he became a pharmacist. Did you take any extra classes or different classes or something to become an infectious disease pharmacist? What's the path for the people in our audience?
Yeah, so a lot of times you'll see, so I had a chemistry undergrad degree, but you will see biochem pop up a little bit more, micro comes in sometimes. For me, it was more the interest. So I knew after that internship, it's what I wanted to do. So I looked for opportunities. I became collegial with one of my professors who was in ID, looked for opportunities. I tailored my P4 rotations to make sure that I got that opportunity. And then I did a PGY1, which is your pharmacy practice residency. Then I did just a PGY2 and ID. But some people, particularly those who usually end up where I am, doing more clinical research, doing more research type stuff, often will do an ID fellowship, which is an option as well. And by the way, by the time you'd be ready, we could keep you here for that. So another shameless plug for the future. So there are definitely different paths. It just really depends on, again, ID. I talked about the clinical aspect and I talked about the research aspect. There's industry opportunities. There's a wide range, and it really depends on where you want to go. And so what I would say is that, again, if you have an interest in learning more, shoot me an email and we can talk.
Wonderful. All right. Well, I think in the interest of time, I'm going to kind of change things up here and thank you for being on the program. Again, the first president ever. I think you did a good job recruiting for SIDP. I hope there's a student rate. Students who are interested there is, of course there is. So they'll contact you. And your email address is up on the screen right now. So you contact Jason this way. And then for the rest of the audience, tune in for our next webinar. We're going to have Professor Tim Cernak from our MedChem department, who just had a recent paper in one of the best journals of any type to talk about how do we manufacture through synthetic chemistry all these anti-COVID agents. So I hope to see you next Thursday, same time, 5:30 on October 1st. Thank you again, Jason.
Thanks for having me. Bye-bye.